Privilege to introduce Amy Holmes here today to speak. So a bit about Amy. Amy graduated with a Bachelor of Science at the University of New South Wales prior to studying medicine at the Australian National University. She graduated in 2007 and completed the majority of her training through the Canberra Hospital prior to travelling to Christchurch for her final year of training. Amy has been a consultant at the Christchurch Hospital ever since and also greatly enjoys being able to support haematology patients on the West Coast and through the St George's Cancer Care Centre. Her interests span the breadth of malignant and non-malignant haematology with a special interest in non-Hodgkin lymphoma. She is a member of various medical organisations including the Australasian Leukaemia and Lymphoma Group, for which she sits on the New Zealand Committee. She is a principal investigator for a range of clinical trials and provides a consultative service to the Christchurch branch of New Zealand Clinical Research. So welcome, and I'll hand over to you, Amy. Thank you very much.
Thank you for that very warm welcome. I'll put a tongue twister into it next time. So thank you for having me at this meeting. It's a real privilege and a pleasure to be able to speak with you guys today about CLL and indolent lymphoma. We've got an awful lot of content to get through. This is a huge topic in a small time frame. So we'll try and cover as much of it as we can, and there'll be time for questions at the end. So hopefully I've pitched it to your level of understanding in this topic. It's something that a lot of people have got great interest in. So I have no disclosures to report. I'll cover non-Hodgkin lymphoma first and touch on a couple of the common subtypes. There really just isn't time to cover them all, but if there's a specific one you'd like me to cover at the end, please mention this. And we'll talk a little bit about the approach to treatment and some of the common treatments that people may be getting exposed to when they do come to therapy. CLL is an exciting field, and we'll talk a little bit about prognostication in CLL, as well as the approach to treatment for this disease and the current treatment landscape. So sticking to non-Hodgkin lymphoma first. What is lymphoma? Hopefully some of you have figured this out by now, but it's often something that people get confused by. Even clinicians sometimes can't tell me the difference between lymphoma and leukemia. So lymphoma is a cancer. It's a cancer of one of your blood cells, one of your lymphocytes, and in non-Hodgkin lymphoma, this can be either your T cells or your B cells. Most commonly your B cells. T cell lymphoma is much less common than B cell lymphoma. And so my focus today is on B cell non-Hodgkin lymphomas. The difference between leukemia and lymphoma really differentiates where it's found in the body predominantly. So lymphoma will predominantly be found in the glands, in an organ called your spleen, as well as in the bone marrow, whereas leukemia circulates within the blood. Leukemia doesn't always mean acute leukemia. People hear the word leukemia and think of very drastic, scary things, but actually with chronic lymphocytic leukemia, this is a much more slowly growing indolent disease. And so people accidentally subclassify it, and sorry if when you were first diagnosed with CLL that caused some level of distress. The lymph glands in the body are spread throughout the entirety of the body, and they circulate with the bone marrow and the organ called the spleen, as well as the liver. So you'll have glands in your neck, in your axilla, throughout the abdomen and the chest, and your spleen is located in the upper left-hand side of your abdomen, whereas your liver's up over the other side. And the approach to lymphoma and leukemia is not one of surgery like you see with solid organ malignancies, because this is all connected. Your blood is circulating throughout all of your body. It's a very different type of cancer. Indolent, which is our focus today, Catherine Neal is talking on aggressive lymphomas at the moment. Indolent lymphomas are diseases that wax and wane over time and progress gradually in the body. And because of this, they tend to be not curative or curable, but also have prognoses measured in years, rather than aggressive lymphomas which present quite quickly and progress steadily and need to have treatment straight away. There are many different types of non-Hodgkin lymphoma. With the focus on indolent lymphomas, the two most common ones are follicular lymphoma and marginal zone lymphoma, which you can see there in the teal colour and the green colour. And these increase as patients and the population ages. They are a disease of the elderly people, and because of that, that has treatment implications. So focusing first on follicular lymphoma, this is the most common indolent lymphoma and a very common cancer within our clinics. The median age at diagnosis is 65, and often it will present with a painless lump or lumps, plural. Many patients may have very few symptoms when they first come to see us. And the diagnosis really hinges on a biopsy. A small proportion of people will have symptoms when they present, and these people are much more likely to have a higher burden of disease or need to go straight on into treatment. And those symptoms that we are monitoring for, we call them B symptoms. Those are fever, weight loss, and sweats at night time. Drenching sweats, not just feeling a bit clammy. We don't really know what drives many of the blood cancers, and that's true for follicular lymphoma as well. The majority of people will have a rearrangement in some of their chromosomes, which causes a change in protein expression within the cells, causing them to become cancerous. And there are a whole raft of other small mutations that happen in different pathways within the cells that drive that change from a normal lymphocyte into a cancerous lymphocyte. When we diagnose lymphoma, in the past, people were given a grade as well as a stage, and this can be quite confusing for patients as well as people who aren't haematologists, because they mix the two up. And so I've included this just so that you have a little bit of a feeling of what we mean when we talk about the grade of your lymphoma. In fact, the most recent approach to classifying follicular lymphoma has moved away from this. And so people who are diagnosed today may not actually be assigned a grade anymore. But many of you will have been diagnosed in the past and will have this on your clinic letters. So the grading of the lymphoma refers to how many of the larger cells that there are within the gland, within the lump of tumour. And the larger cells you can see increasing as you move from grade 1 through to 2 and up to 3. And in fact, the only group where grading is still important is in grade 3B. And that's this one here, where there's quite a lot more of those larger cells there. And those people are treated in the same way as we treat diffuse large B-cell lymphoma in the bottom left-hand corner, with chemotherapy up front and a more aggressive approach to treatment, because they behave in the same way. The earlier grades are all treated exactly the same way. And so because of that, the new guidelines on pathologic classification of this have moved away from grading. The second most common type of indolent lymphoma is marginal zone lymphoma. This is an interesting disease. There's lots of subcategories of marginal zone lymphoma, and it depends on its clinical behaviour and where it's presented. So the first is splenic marginal lymphoma. The splenic marginal lymphoma will present with enlargement of the spleen. It may cause low blood counts, and there may be circulating lymphoma cells that we can actually see down the microscope. And it involves the bone marrow as well, but a lot less nodal involvement with splenic marginal zone lymphoma. Nodal marginal zone lymphoma typically presents as a painless lump similar to follicular lymphoma, and it's really only differentiated between the two on the basis of that biopsy that's performed. And then you have extranodal marginal, it's a mouthful, extranodal marginal zone lymphoma. And this is often driven by infection in the body. It presents in organs that have contact with the external world particularly. So in the gut, in the eyes, in the lungs, and often there's a driver, an autoimmune process or an infection that's caused the immune system to become dysregulated and develop into a lymphoma in those sites. that may have implications for treatment, because sometimes improving the control of that infection, for example, in the gut, it's often linked to an infection called Helicobacter pylori. And so treating that bacterial infection can sometimes cause regression and improvement in the lymphoma. So that's quite cool. The next indolent lymphoma I'll touch on, and the final one I'll have time to specifically refer to, is lymphoplasmacytic lymphoma. And this is a really interesting lymphoma as well. It's also called Waldenstrom's macroglobulinemia, which is an awesome name. So this lymphoma is special in that it also causes overproduction of antibodies in a lot of patients. And it's an IgM antibody that they overproduce, which is this flowery looking one down the bottom corner. And you can see how much bigger that protein is compared to the IgG molecules above it. Because it's so chunky, when your IgM level really increases in your circulation, it can cause your blood to become thick and viscous. And because of that, people can have circulatory problems with this type of lymphoma and need to go on to special therapies before it. And that's one of the indications to treating this lymphoma, is how high is that IgM causing? Is it causing problems with the viscosity of the blood, the thickness of the blood? So that's a special thing to this one. Lymphoplasmacytic lymphoma also is treated just slightly different to the other two. There are some different chemotherapies that people may be exposed to, but also it may be more likely to respond to some small molecules which aren't funded for this entity, but are quite effective and pretty well tolerated. Non-Hodgkin lymphoma, although there's lots of subtypes, are all classified and staged in a similar way. So some of those lymphoma types that I've just touched on will almost always present as stage 4 disease, like splenic marginal zone lymphoma, Waldenstrom's macroglobulinemia. They always really involve the bone marrow or the spleen. And so because of that, staging in those cancers actually isn't all that relevant. But particularly with follicular lymphoma and some of the other ones, it does become relevant because it has treatment implications. A small proportion of people will present in stage 1 disease, where it's really only involving one nodal group in the body. Stage 2 involves 2 nodal regions, but both on the same side of the diaphragm. Stage 3, above and below the diaphragm, and stage 4 then involves the bone marrow or the spleen or other extranodal kind of areas. We can then use this in our prognostic scores, and the FLIPI is particularly used in follicular lymphoma prognosis, and that integrates the stage of the cancer as well as the age of the patient, their hemoglobin, because that's an indicator of how much burden there is in the bone marrow, the factory that's making their blood, as well as the LDH. But perhaps the more important prognostic factor for follicular lymphoma is actually your response to treatment. We know that people who have their lymphoma come back within 24 months of them having that initial line of therapy for their lymphoma do worse. They have a worse outcome. And that sometimes is a reason in younger patients to actually consolidate and intensify their treatment. So treatment options and are focused on follicular lymphoma and marginal zone lymphoma on here, but many of the other indolent lymphomas will follow a similar path to this. If you have limited stage disease, it's in one radiotherapy field, and it's in a site that's tolerable to have treatment with radiotherapy, that may be the most appropriate thing to do in the first line, because you can cure some of these patients with radiotherapy. However, if the disease is more widespread and it's not able to be encompassed within one radiotherapy field, the treatment really comes down to watching and waiting with these patients, active surveillance, until the lymphoma is built up enough to cause a problem. Hopefully we anticipate this because before people become unwell from their lymphoma, and it's always a little bit of a juggling act to try and pick the right time for the right patient. Because there really isn't a benefit to early treatment when patients are at early stage disease. It exposes them to all of the toxicity of chemotherapy sooner than they need to, and doesn't improve their long-term outcome. And many people will live with indolent follicular lymphoma, stage 3, slowly grumbling along for many years without actually needing to come to treatment. When things become high enough of a disease burden or they become symptomatic, and we broadly use the Guelph criteria to determine that, which looks at the number of nodal sites that are involved and how big the lymph node is, or whether it's starting to cause abnormal blood levels with your platelets or your neutrophils, or whether some of those B symptoms are starting to creep in. People are starting to lose weight or have sweats or excessive fatigue. And then we come on to looking at their treatment options. And people will oscillate between, these are the most common lines of therapy, and you have a treatment episode when you come to treatment, and then the disease will regress, and then you go back into that active surveillance phase before you come up to your next line of treatment. So the most common lines of therapy that people will move through are bendamustine, which I'll focus on a little bit more detail in a moment, because it's also used in chronic lymphocytic leukemia, and it is really one of the most common chemotherapy regimes that is used for marginal zone lymphoma, lymphoplasmacytic and follicular lymphoma these days. RCVP and R-CHOP are very appropriate chemotherapy regimes as well. They're a little bit older than bendamustine, but they work very, very well, and they're often fairly well tolerated still. Lymphoplasmacytic lymphoma, we also throw in some cyclophosphamide orally and dexamethasone in some patients as a gentle way of just shrinking down that lymphoma and bringing down that IgM level enough that it's no longer thickening the blood. But they can also sometimes respond well to ibrutinib. It's an access issue that will limit us using that medication. Patients will go through this initial phase of chemotherapy, and then particularly in follicular lymphoma, they are eligible in New Zealand now for maintenance rituximab, which is a monoclonal antibody against the lymphoma cells, given once every 2 months for a total of 2 years. And the idea of the maintenance rituximab really is to extend the period of time before the lymphoma comes back. There isn't a huge survival benefit. There was a trend in the studies towards a benefit in survival, but it didn't actually meet statistical significance, but that's the goal. And the people who are going to benefit the most from maintenance rituximab are the people who still have a small amount of residual disease after they've been through that initial run of chemotherapy. Of course, being on a monoclonal antibody that's wiping out your B cells for 2 years has implications to your immune system. And so it does become a little bit of a clinician decision and a discussion with the patients as to whether that's actually something that we should do or not. Because if your disease is very well controlled, but actually you've been struggling quite a lot with infections during your 6 cycles of your other chemotherapy, some patients it may actually be the better decision to say, well, actually, no, we're not going to do maintenance, particularly in the times that we have now when we're so much more aware of infections. If the lymphoma comes back early after you've had rituximab, obinutuzumab has been funded now for this indication in marginal zone and follicular lymphoma just in the last 12 months. And so they can have that added into their next line of chemotherapy. And that's a stronger version of rituximab. I mentioned before that we may intensify the treatment in some people, particularly if we find that their lymphoma comes back soon. So if your lymphoma is coming back quickly, and you're young, a proportion of people will have what we call an autologous stem cell transplant as their second line of chemotherapy. We wouldn't do that up front, but when their lymphoma comes back, to try and really control the disease the best that we can in that second line of chemotherapy. So moving on, I mentioned rituximab. So this is basically thrown into all B-cell disorders treatment up front. It's been with us now for a bit over a decade, and it really revolutionised, well actually no, probably 2 decades, treatment for lymphoma. It's an antibody that targets CD20, which is a protein on the outside of all B cells. And it allows your immune system to recognise that those are abnormal cells and destroy them, and also causes some direct toxicity to those B cells to help the chemotherapy to wipe them out. Because it's not chemotherapy, most people find that actually it's pretty well tolerated. So yes, we might suggest that you stay on treatment for an extra 2 years with maintenance infusions. Often this might cause you to feel a bit tired on the day that you have it, maybe for a day or two, but it won't be as intensive, won't run people down as badly as chemotherapy does. It does cause infusion reactions, particularly the first time that you receive rituximab. And so those of you that have been through active therapy will remember the first day that you come for chemotherapy is a big deal. It goes for a really long time. And that's because that rituximab needs to go in gradually. We'll give pre-medication before you come in for chemotherapy with antihistamines and paracetamol, but you need to go quite gradually and stop and start, particularly in people who've got a lot of lymphoma in their bodies at the start. Bendamustine is probably now the most commonly used chemotherapy for first-line treatment of follicular lymphoma especially. That comes out of the Bright and Still studies, which demonstrated that bendamustine was better tolerated than R-CHOP and those other lines of chemotherapy in patients. And the reason being is that it had lower rates of neutropenia and neutropenic fever. But bendamustine is actually very immunosuppressive. It does lower your immune system quite considerably and for a longer period of time probably than what you would experience with just R-CHOP, because it will lower the T cells and the B cells so drastically. So that's a little bit of a quirk of bendamustine, is that we have to be mindful of the immune suppression that people have when they have this. And I think it's partly because of that actually maintenance rituximab in this group had a lesser role. And there's some studies that have suggested that the infection rates that patients had with rituximab after they'd gone through bendamustine were so much higher that actually it sort of negated any benefits. So it may be a reason why your haematologist has chosen not to put you onto maintenance rituximab, for example, if you've had bendamustine. The other things that are specific to bendamustine is that it has a lot more rashes than a lot of the other chemotherapies we see. We can usually work through those. It doesn't mean that we have to stop, but it can be a troublesome thing at the start. It does irritate veins, so some people will need to have a line popped in for their chemotherapy. But hopefully it doesn't cause hair loss. And so patients quite enjoy that. New things, new kids on the block. Lenalidomide is something that's accessible overseas, and it, in some settings, would be the second-line chemotherapy that people are using for follicular lymphoma, for example. It's not funded in New Zealand. Some patients will purchase it privately. And it can be helpful when people have been through multiple lines of chemotherapy and they've gone through all those common agents that we usually use to approach their lymphoma in a different way. And then you start looking at what else. And really the best place to access the what else is through a clinical trial. And I think clinical trials have a huge role in haematology. A lot of the other agents that you can see that are out there for follicular lymphoma and other non-indolent lymphomas are very expensive. And the best way to access them is through a study. Some of these will act on molecular pathways that are increased in the lymphoma cells to try and decrease the drive that's in the cancer cells to grow, such as the PI3K inhibitors and the EZH inhibitors. Or otherwise, the sort of new kid on the block and the real growing interest in haematology is using the natural immune system, the T cells in the patient, to help to control the disease. And that's with things like CAR T cell therapy or BiTE antibodies. So with CAR T cell therapies, I'm not going to talk about it very much because we've got a whole session dedicated to that, and that's Rob Winecove's baby, and it, I'm sure, is an excellent session and will be recorded. So CAR T cell therapies take the T cells from the patient, modify them and sensitise them to the cancer cells, and then the cells are reinfused and help to control the disease. The difference with BiTE antibodies is it's off the shelf. So it's an antibody that bridges between the antigen or the protein on the outside of the cancer cell and the person's own T cells, and brings those two cells together and helps them to attack each other. And so that's a really exciting option for people who have chemotherapy refractory disease, people who have been through lots of lines of therapy and actually it's no longer working with chemotherapy. How can we treat these people in a different way? In practice in New Zealand, if you don't have access to a clinical trial, if you're young and you're fit, it may be an allogeneic stem cell transplant that we actually propose. But there's a lot of patients with follicular lymphoma who are older who just aren't able to have that. So that was all I was going to cover with follicular lymphoma. I might whip on into CLL, but please store up your questions and I can come back to them at the end. So CLL and SLL are essentially the same condition. We talked before about the difference between lymphoma and leukemia. So CLL, those patients will present with their disease in their bloodstreams. It will build up over time in the spleen as well as in the bone marrow, whereas small lymphocytic lymphoma may have a totally normal lymphocyte count on their blood test, but enlargement in the glands. And over time, they can get more and more glands being involved, but in the strictest sense, they don't actually have a leukemic population at all. There's nothing on their blood test. Many people with CLL are in the middle. So they have a bit of a mixture. They'll have enlargement of their glands. They'll also have it in their bloodstream. We treat them exactly the same.
Sorry.
That's okay. Diagnosis for CLL is on a blood test. So this is one of the rare areas of haematology where we don't need to go biopsying you and putting you through lots of invasive tests, because CLL and SLL have such a classic pattern of proteins on the outside of their cells that a blood test tells us so much information that we can actually pigeonhole a lot of people and give them a diagnosis simply with a blood test, which is quite cool and more comfy for you. It's a common cancer. It's a cancer of the elderly. And in many patients, the focus initially is active surveillance. And we'll cover a little bit of why that is in a little bit. The majority of people will be picked up incidentally. They've gone to their GP, they've had a blood test for some other reason, and the lymphocytes are found to be high. That's the B cells that are on your blood test. In most patients, that will occur so early in their disease that their hemoglobin may be normal, their platelets may be normal, they've got no symptoms of their disease at all. But a small proportion of people will have B symptoms even from the get-go. The other thing that's a bit of a quirk with CLL is some of the immune implications of having this condition. And so a reasonable proportion of people will have derangements in their antibody production driven by their CLL clone. And those people may have immune destruction of their platelets or immune destruction of their red cells. And for those people, they may need slightly different treatments. The other thing that we see in CLL, and particularly this increases as patients progress through their journey, as that CLL burden increases in their body, and then especially after they've gone through treatment for their CLL, is a lowered immune system and lowered production of antibodies in their body. We call it hypogammaglobulinemia. I've trained for a long time to say these words. In some of these people, we actually give them antibodies from the blood bank, from New Zealand blood donors, that are then purified and infused once every month. That's only really appropriate if people have had recurrent infections. But if you do have an indolent lymphoma, especially if you've had treatment for your CLL or your indolent lymphoma, and then you're struggling with infections, your haematologist will look and see what your antibody levels are. And if they are really low, then that can be an important adjunct to your treatment to try and improve the supportive care. A small proportion of people with both indolent lymphomas and CLL will have their disease change. And so it can evolve into a more aggressive lymphoma, diffuse large B-cell lymphoma. Particularly in people who that happens to who have CLL, that's quite a bad thing to have happened. And we get quite concerned about that, but it isn't common. It's something that we always counsel our patients to let us know, because if they suddenly start developing a lot of symptoms or a lymph node really starts growing quickly, it's a reason to biopsy, it's a reason to make sure that things haven't changed. As you can see, CLL is a disease of the elderly. It really kicks up as people get up and over sort of 60 years of age. And because of this, that has huge implications for treatment. Thankfully, in the modern era, we're increasingly able to work around that. But winding back the clock 10 years ago, this was a major problem because we just didn't have chemotherapy that suited that population of patients. So prognostication. There are a range of things that we can use to prognosticate in CLL. In practice, not all of these are used. And that's because they don't really change our decision to treat patients, and it doesn't really change which agents that we use. But we'll work through them because a lot of you may be hitting the books and coming up against a lot of these things. So it's good for you to have the tools to understand what we're talking about. The first ones are really focusing on how much bulk of CLL or SLL is there in the body. The staging systems for CLL were developed in the 1960s. They're ancient, but they're still relevant because they give you a feeling about how much disease has accumulated. And those look crudely at how many lymph node areas of the body are involved and what's the impact on the blood tests. The Ryan-Bennett staging systems are the ones that I'm referring to, and they still have implications and significance now. The lymphocyte doubling time is particularly handy, and we do definitely use this, and particularly we use it to help your primary care physicians because many people with CLL are in the community. They may never have met a hematologist. And we use this as a bit of a guide as to what's the tempo of that person's disease. Is it growing rapidly? Is it doubling within 6 months? Because people who have that kind of a progressive rate are more likely to come to need treatment soon. Doesn't mean they need treatment now, but that population has the kinetics of their cancer that it's likely that eventually they'll come to have treatment. Beta-2 microglobulin, again, is just a measure of bulk of disease. Immunoglobulin gene rearrangement status. This is an interesting one. So IgHV mutation status is not commonly tested, largely because it's difficult to access. It's a send-away test. It costs a lot of money, and we don't get the result for 2 months anyway. But also because it doesn't really change our treatment choice in the majority of patients. The people who it does help us with deciding treatment in are the young patients with CLL. It will be in lots of literature, especially from overseas, for prognostication of CLL, because this is a marker that we've known about for many, many years as being a predictor of people who are going to be more sensitive to chemotherapy or who've got disease that is going to have a better prognosis. And so people who have a mutation in their IgHV gene have a better response to really any treatment that we give them, which is great. About half of CLL patients will have this mutation, but it's not changing what we're doing, and so it's not necessarily always tested. What does have implications for treatment and is really important for us to test, and is often now tested every time people are coming to a treatment episode, is the 17p deletion and the p53 mutations. And these are really important. On the short arm of chromosome 17, the p53 gene sets. And if you lose one or both of your p53 proteins, you lose a tumour suppressor gene. The tumour suppressor genes are important in your cell's ability to mount a response to cell damage. So if a cell becomes damaged because the chemotherapy has had its effect on the karyotype or on the chromosomes, then that gene tells the cell, you're damaged, you die. If you lose a tumour suppressor gene, you lose some of your ability to, or your cell's ability to mount a response to that kind of damage. So they become resistant to chemotherapy. For that reason, we know that people who have these mutations have a worse outcome. They don't respond as well to chemoimmunotherapy, and that's a major concern. Thankfully, now we have targeted therapy, and people who have these genes will do better on targeted therapy. but they still don't do as well overall. And so your haematologist will be looking for this, especially when you come to treatment. There are many other genetic changes that we can look for, and they do what we call FISH, which means fluorescent in situ hybridization. Basically, we bind probes to the karyotype, to the chromosomes in the laboratory, and they fluoresce if there's a change in those specific places. And this is the general panel that people use for CLL. The main one that's important is 17p, and you can see that 17p deleted patients who are there in the blue are dropping off much more quickly as to when they're going to need to start treatment, which is at the top, or what their overall survival is. And I need to point out to you that this is from 2016, so this is before we had our new targeted therapies, okay? But it demonstrates to you how concerning those mutations are. Equally, there are some people who will have favourable mutations, which is the deletion 13, and those people up the top in the red do much, much better and can go for a long period of time before they actually need any intervention for their CLL at all. So we now have the CLL IPI score, which integrates all of these things and brings them together and can tell us when we first see a patient in clinic how they're going to behave. And we don't tend to use this in practice because, again, it doesn't change our management and because we're not often doing all of those tests to bring it all together. But I use this as a demonstrator to show you how well some people will do with CLL who are early stage, who haven't got one of those poor mutations. And those people can go with active surveillance, with monitoring for many, many years or decades with disease that never really comes to needing attention from a haematologist. And that's the line up the top. So the picture at the top is showing you time to intervention, time to treatment for the first patients from diagnosis of the CLL. And people who are in that favourable group are going for 6+ years without really needing anything done for them. That line's nice and flat. We don't need to see those people. The people who have higher risk CLL, who have got that higher doubling time, who have the kinetics that it's growing, are more likely to need to come to see us. And you can see that this score is weighted for those high mutations, for the 17p deletion and the p53 mutation, because those people have a much shorter amount of time before they come to needing to see us in the clinic and starting on treatment. Those are in the purple and the red. So I've just said that lots of people don't need anything. What can you do? Lots of people are out there on active surveillance, and that goes for the indolent lymphomas as well. So the important things for you to do when you're in that active surveillance, that monitoring phase, is be aware of your health. If something changes, see your primary care doctor. Let them know. You're suddenly having new symptoms. There's a lymph node that suddenly started growing and seems abnormal. You know, tell someone about it. Don't sit on it just because you're being monitored. Equally, look after your health. Exercise, be attentive to your diet, improve some of your comorbidities. It's going to mean that you're so much fitter when you actually come to meeting us in the clinic and needing to start treatment. Because CLL does impact on your immune system, even if you haven't had treatment yet, make sure that you look after your infectious risks. Be vaccinated, and be aware of the fact that you can be having a slightly higher risk of particularly chest infections with CLL. And malignancy screening is the big one. So people who have CLL have a reduced surveillance of their body for cancer cells, and particularly that applies to the skin. So making sure that you use sunscreen, you get an annual skin check. To look for low-grade skin cancers and keep up to date with all your other sort of cancer screening. We do eventually have to start treatment. I can't pretend that we don't treat CLL because I treat CLL all the time. So when do we treat it? We treat it when it's becoming a problem. So when people's blood counts start to drop, they become anemic or thrombocytopenic, their spleen starts to become enlarged, they have B symptoms, or disease-related symptoms. These are the reasons why we would get on and start treating their CLL. And the scope of what treatments are out there as quite confusing for people, because lots of people will be on different treatment for their CLL. And that's an exciting thing, to have options that we can tailor the treatment to the patient now. If you have a adverse gene or a 17p deletion, we know that chemotherapy is not going to be the right fit for you. So we now have funded venetoclax, and people will go on to venetoclax tablets as a single agent until their disease progresses or there's toxicity. And then we have ibrutinib as their next line of therapy. On the other side of the line, if people aren't mutated for those genes, they still need to have chemotherapy in their first line of therapy in New Zealand. And we then adjust it to their fitness. If they're young and they're fit, and especially if they have that IGHV mutation that we know predicts that they're going to do well on chemotherapy, and especially on RFC chemotherapy, they may go on to an intensive chemotherapy of rituximab with tablets for fludarabine and cyclophosphamide. And sometimes those patients will have really deep, really protracted responses to that chemotherapy for 10 plus years. Their CLL is gone, we don't need to worry about it anymore for a decade. Not in all patients, but there's a proportion of people who do so well. RFC chemotherapy, though, isn't a walk in the park. It causes nausea when people are on it, and it lowers the immune system quite considerably and can damage the bone marrow cells, so that we don't want to use this if people are mutated, are unmutated, or if they're older, because it does have side effects. So in the people who are older, who are moderate in fitness, bendamustine that we talked about before is their first line. Or in the frail patients, we use a stronger form of rituximab, obinutuzumab, with tablets of chlorambucil. And that's very well tolerated, in fact. So it's getting to the point where even very frail elderly patients still have a treatment option for their CLL, which is pretty exciting. If the disease progresses and reoccurs within 72 months, you can then go on to targeted therapy within New Zealand. And the first line for that is still venetoclax. Internationally, for those of you who are hitting the books, the landscape for CLL is a bit different. And that's because we know that exposure to chemotherapy in the CLL cells drives mutations, and people will tend to develop resistant mutations each time they're exposed to chemotherapy. And so the current approach internationally would be to say, well, let's not give them chemotherapy. Let's target small pathways in those cells to destroy their cancer cells without the added toxicity of chemo. Especially if people are unmutated with IGHV gene changes, because we know that those people do worse with chemo. And so I'll cover the venetoclax and ibrutinib, which are two of the main classes of these targeted agents now. So new drugs. There's lots of pathways in CLL that are deranged, but the two main places that we can intervene are at the BCL2 and at the BTK. So venetoclax first. Venetoclax became funded in New Zealand on the basis of the Murano study, and thank you to anyone who was here and part of that study. I know that we had patients on this in Christchurch. We were certainly heavily recruiting to it in Canberra, where I was working at the time, and it was a great option for our patients at the time. So enroll in a clinical trial. Murano compared bendamustine with venetoclax in relapsed refractory CLL. So this wasn't upfront. This was in people, some of which had many lines of chemotherapy before they got to this. And it had clear benefits. The top graph shows you time to next treatment. And people who were on venetoclax carried on for a really long time after that initial therapy without really needing to come to a second line, or a next line, I should say, of chemotherapy. And there was an overall survival benefit as well eventually. Venetoclax is given in for 2 years as a fixed duration treatment in combination with rituximab if you don't have a CLL mutation in 17p or p53. Those patients are treated indefinitely or continuously. It's an oral therapy, so it's tablets, and it's pretty well tolerated. The way that it works, BCL2 is a protein that's upregulated in lots of cancer cells, and it has a binding site on it where a protein that is proapoptotic binds. And so venetoclax comes in, it displaces that proapoptotic protein, which then goes off to the mitochondria, which is part of your cells, and says, you need to die now. And so by displacing that protein, it causes cells to go through a death pathway. It's a tablet, it's not chemotherapy, so it must have no side effects. Not true. Every drug has side effects. Just because we don't call it chemo doesn't mean that it's a walk in the park. So neutropenia, especially at the start, as patients stay on venetoclax, the neutropenia tends to be less of an issue. And one of the biggest things that's quite specific to venetoclax is that it works really fast. And so because of that, in people who have CLL, who have lots of disease in their body, if we came in and gave them the full dose right at the start, those cells will all die really fast, and it will clog up the kidneys and cause what we call tumour lysis syndrome. And in fact, the development of this drug was a little bit stalled initially because people developed tumour lysis syndrome from it. We've never seen tumour lysis syndrome from CLL until we had this drug. But now we know how to manage tumour lysis syndrome, and the reason why, if you've started venetoclax, there's a very, very gradual ramp up of the dose with lots of blood test monitoring is because of this. It's to try and protect the kidneys. And we can usually get around this pretty well now that we've got a good schedule for being very gentle with it. Infections are always on the list, and sometimes some gut toxicity or tiredness. But generally speaking, it's pretty well tolerated. The other thing that's worth your GP being aware of and you being aware of is that it does interact with a bunch of medications, particularly some antibiotics and antifungals. So it's good for your GP to be just mindful of that. But they're often, so checking these things pretty attentively. The second targeted molecule that we'll touch on briefly is ibrutinib. So it's acting at the BTK inhibitor, which is part of your signalling through the B cell receptor on the outside of the cells. By blocking that, it stops a whole cascade of intracellular signalling in the cells, which is upregulated, which stops their drive to keep growing and proliferating. Because it also acts, down here, it changes the binding of the B cells to the microenvironment, to where those B cells, those lymphoma cells like to live. And that has some implications in the clinic as well. Again, oral therapy, tablets, also effective in some other, sorry, I'm touching my mic, in some other malignancies such as the Waldenstrom's that I mentioned earlier and mantle cell lymphoma. And because it changes the interaction of those lymphocytes with the microenvironment, often patients will have quite a quick shrinking of their lymph nodes or of their spleen, but actually in their blood test, those lymphocytes can start to climb. And it redistributes the cancer cells. So don't be alarmed if you've started ibrutinib and we go and do another blood test and all of a sudden your lymphocyte count's doubled. That's okay. That's the drug working. It's part of the mechanism of the drug. There are very specific side effects with ibrutinib, and particularly they can be more cardiac. And so that's quite different to a lot of the other drugs that we're using. It can cause an irregular heartbeat, atrial fibrillation. It can cause high blood pressure, which actually accumulates that risk over time. So because this is a drug that isn't taken for a fixed duration like venetoclax, it's something that people are on indefinitely until their disease progresses. Some people are on this for 5 years, longer. So over time, you need to be mindful of things like blood pressure and your cardiac risk factors and monitoring for that. Another thing that's quite specific is bleeding. It inhibits platelets. And so if people are on this medication and then come to needing surgery, we actually need to stop it prior to them having procedures done because it will be increasing their bleeding risk. And some people will have bleeding complications whilst they're on it. And infections. I've mentioned infections lots. Rob Wynekove is talking after lunch about infections. It's his baby along with CAR T-cell therapy. And so I encourage you to go along to that because people with CLL are more prone to infections. And that risk only increases with time. It only increases with treatment. And so you can see that although the majority of people who are having infections, it was peaking in that first year that they were having their ibrutinib, actually even the grey bar right there on the left, where people have been on ibrutinib for 5 years, still 10% of them were having grade 3 infections. A grade 3 infection means that you've needed to go to hospital because of your infection. So these tablets are really, really well tolerated. People have a normal quality of life on them. Their CLL is excellently controlled, but just don't forget that you do need to be mindful of these things. So CLL, it's a really exciting time to be working in CLL. I won't say it's a really exciting time to have CLL, that's not fair. There's lots of development, lots of increasing understanding of the condition, and more to come. So our access to medications for CLL in New Zealand actually has improved quite a lot in the last 5 years, which is exciting. So I'll open up to questions, both on CLL and indolent lymphoma. I think we've probably got a few minutes.
Do you think I need that? Okay. I've just got a couple of quick questions. You mentioned about lymphoma. There's obviously a lot of people on watch and wait, and you mentioned about the actual measuring of the results wasn't so effective on the blood test as it is more in the, unless I've got confused, the lumps and the growing and the change in the lumps because it's in the lymph nodes rather than with like leukemia, that the blood results may not be as clear if there is progression of the disease.
You're talking about the
lymphoma.
SLL rather than CLL.
I'm talking about non-Hodgkin's lymphoma,
Okay.
follicular lymphoma.
So in non-Hodgkin's lymphoma, we still look at the blood tests.
Yeah.
Those are really important to looking at anemia or thrombocytopenia, which will occur as the lymphoma grows in the body and builds up, because that can become a reason to treat the disease. Very occasionally, people will have non-Hodgkin lymphoma cells circulating in their blood tests too that we may be able to see. I think you were thinking of when I was talking about CLL versus SLL and the difference between the two, because in SLL, they may have a completely normal lymphocyte count, and we can't measure their doubling time looking at their blood test like we would with CLL, where the lymphocytes are in the circulation and you can see them growing just on a blood test. In follicular lymphoma, clinical exam is really important to feel for the glands growing.
That doesn't happen for people on watch and wait.
No, but it should do through their primary care physicians. And many patients will be in watch and wait in haematology follow-up as well, where they're coming to see clinicians, and they should be getting examined regularly every, depending on their stage of their disease and where they're up to, every 6 or 12 months. And that's the only way to measure how things are progressing.
Right. So, like my husband's been on watch and wait for nearly 11 years.
Oh, that's a really long time. That's excellent.
Yeah.
That's a very, very favourable thing.
And, but in the last 12 months when we moved, he's only had one examination by a GP, so they don't do physical, unless I guess we have to be more active. Like I monitor his blood results now, but obviously we would have to be active in making an appointment and asking them to check his, because he is stage 5, whatever the stage 5 or 4 or whatever it is, but only grade 1. But
Right.
My last question was, is it possible to get confused between the two types? You mentioned about the Helicobacter and how the other type of lymphoma, I can't remember, I think it might have been mantle cell lymphoma. There's a two.
So with marginal zone lymphoma, there's an extranodal form of lymphoma which is often driven by underlying infection.
Yep.
That's very specific to extranodal marginal zone lymphoma.
That couldn't be mistaken between the two?
With follicular lymphoma?
Yeah.
No.
Okay.
It comes down to the biopsy. If there's been a biopsy, then,
Yeah.
then the histologist will have looked at specific patterns and gene changes as well sometimes
Right.
that will occur between the two, and that helps them to classify each condition into its own group.
Because
Yeah.
he gets a lot of those symptoms that came with that other one that you talked about.
Right.
Yeah.
Yeah.
It's just interesting.
Hi. I just want to know why we don't get a FISH test when we are diagnosed with CLL to tell us our mutation or deletion, so we know.
So the reason is because CLL is really, really common, and it is an expensive test, and it also doesn't inform on how long it's going to be in the majority of people before they need to come to see us. The patients who have those high-risk mutations will have lymphocyte counts that grow quickly. And so it will be clear just from their blood test monitoring that actually that's the population that needs to be pulled out. And there's lots of education that goes out to the GPs. They write to us all the time so that we can screen out who those people are and say, well, actually, yes, these people need to be seen. And often when they then come to clinic, particularly if they're getting closer to the time that they need to be treated, then all those tests will be done. Testing the P53 mutation or the 17p deletion early in disease actually doesn't mean that we don't need to then repeat it when people come to treatment, because sometimes, particularly that mutation, is one that can accumulate over time, and so that's the reason why it's often repeated. So if you have people who've got really early stage disease and you're checking it, actually you're spending lots of money, but it doesn't change, you know, where they're at. So we need to recheck it when they're coming to treatment. That's the time to do it. Yeah.
Thank you.
Have we time for one more question if there is one? Otherwise we'll wrap up.
One thing you haven't mentioned is shingles.
Yeah, so that's one of those mini infections, and absolutely shingles is increased in people with CLL, especially once they come to treatment.
I was just thinking how important it is that people should know that the year that they are 65, they can get the
shingles vaccine.
the shingles vaccine for free, and it is the only time that you can get it for free.
Yeah.
So it's worth people knowing that. I think.
Absolutely, yeah, and all the vaccines. I'll never say no to someone who's called and asked for a vaccine. So the shingles vaccine used to be a live virus, the old vaccine, and you can still get that one. But if people have a lowered immune system, especially people who are on chemotherapy for their CLL, they shouldn't be getting a live vaccine. And often in people who have come to treatment, we actually give them antiviral medications to decrease their risk of shingles. But you're absolutely right. In the last year or so, they have funded a non-live vaccine against shingles, but they're only rolling it out for people who are 65 then. And so if you're 65 at the moment, go and get yourself a vaccine, because it is safe for people to have CLL to have, but it's expensive if you buy it outright.
And like you said, you shouldn't have anyway.
I'm sort of with this one here because I didn't get my shingles vaccine when I was 65. Because when I got the renal cell lymphoma at 66,
Yeah,
and then got shingles which last 10 months.
yeah.
And, you know, the pain, it's just not worth it. So if anyone is close to 65, but I believe it's $600, I got told.
I think so, yeah.
So what I said to my doctor is just keep it on the tablets. I have a tablet every day for the rest of my life.
Yeah,
I'm not prepared to pay $600 for it.
and certainly people, once they've gotten to that point of needing to have treatment for their CLL, and especially if they've had shingles already in their life, sometimes we do just leave them on valacyclovir prophylaxis long term, because even if you vaccinate people who've got advanced disease, their ability to respond to those vaccines is reduced. It's not zero. So, you know, we still think that people should be having vaccines if they can, but it is reduced. So yeah, sorry that happened to you. I think the GPs are onto it a little bit more. I think they send out mass information to people who are turning 65, but you may have missed the window.
Last question.
I don't need the microphone. If you have a pink dot on your thing, it might be quite nice for those of you who have got the same strain, CLL, to meet up in a certain part of the dining room at lunchtime, so we can just network and talk.
Great idea.
You know, it's a really good way just to find people who have got the same thing.
It's a great idea. Yeah, while you're all in the same room. Great suggestion. And thank you so much, Amy. Thank
That's
you.
okay.
We really appreciate your time, and the presentation was amazing. So much informative information, and I'm pleased that, I know you probably weren't pleased it was recorded, but I am, so I can go back and listen to all the slides and re-watch and pause, and so thank you very much. There's a gift from us.
Oh, thank you very much.
And yes, we do really appreciate that.
Thank you.
So thank you. And now it is lunchtime. So lunch is downstairs. So there's the lift and the stairs, and then we're back upstairs for the afternoon sessions. So we'll see you soon.